Welcome to the Deep Dive. Today, we're taking a really structured look at, well, a critical process in occupational medicine.
The National Registry of Certified Medical Examiners exam.
Exactly, the NRCME. This is the gateway, really, for any healthcare provider who wants to certify commercial drivers.
And these are the people whose health, directly impacts public safety on every single highway. It's a huge responsibility.
It really is. So for our deep dive today, we're drawing on some comprehensive source material that covers, well, everything.
Right. From the training rules, the exam logistics, all the way down to the very specific clinical guidelines from the DOT and the FMCSA.
And the mission here for you is clarity. We want to give you a functional map because the real challenge isn't just the medicine you already know.
It's the mindset shift. That's the key.
It is. Understanding the huge difference between being a treating clinician and suddenly being a medical examiner who is only focused on fitness for duty. Okay, so let's start with that path to certification. Before we get into all the clinical details, you have to understand the logistics of just getting in the door. Who is actually eligible to become an ME?
Well, the field is surprisingly inclusive. We're talking about MDs, DOs, DCs, that's doctors of chiropractic.
Right.
And also advanced practice nurses. So that includes your APNs, APRNs, NPs, and of course, physician assistants, PAs.
It's a pretty wide net. But the first real barrier to entry is the mandatory training, isn't it?
Absolutely. You can't skip it. You have to complete an accredited training program, and that gets you the all-important certificate of completion.
And that certificate is basically your ticket to the next step.
Right. Applying for an FMCSA account and then getting your unique 10-digit national registry number.
And if you manage all that, you're certified for 10 years. You can perform these exams in any state where you hold a license.
Now, let's talk about the exam itself. The test is in person. You have to make an appointment.
And it's through two main companies, right? Prometric and PSI.
Exactly. And it's worth noting that PSI actually acquired another company, Chimera, back in 2016.
So if you pull up and the sign looks a little old, you're probably in the right place. Good to know.
Right. And they do try to make it accessible. I saw that Saturday morning testing is an option in most places.
For an $80 fee?
Yep, $80. And for that, you get a pretty high security experience. You have to bring your state-issued photo ID, a copy of your medical license, and that certificate of completion.
And they mean high security. It's a closed book exam all on a computer.
Oh, yeah. They wand you at the door. No pens, no paper, no phones allowed in the testing area.
It really shows you how seriously the DOT takes this.
It does. So for the structure, you get 2 hours. And in those 2 hours, you have 120 multiple choice questions.
4 choices, 1 right answer. But here's the catch that I saw, and it feels a little sneaky.
The pilot question.
Yes. Only 100 of those 120 questions are actually scored.
Right. The other 20 are ungraded pilot questions. The FMCSA is just using them to test out new content.
But they're completely indistinguishable to you as you're taking the test.
Exactly. So you have to treat all 120 as if they count. You have about 1 minute per question.
And what are they testing content-wise?
It breaks down to about 60 to 70% on the actual NRCME regulations, the rules. And then the other 30 to 40% are clinical questions.
So your general medical knowledge, but applied through that specific ME lens.
Precisely. And you have to hit 71% to pass.
The good news is you get your score immediately. The bad news.
The official certificate can take up to 3 weeks to arrive by email from the DOT.
And what if you fail? I saw a really important update on this.
Yes, this is a big improvement. There is no longer a mandatory 30-day waiting period to reschedule.
That's huge.
It is. You can try again as soon as the FMCSA updates your account, which can be, up to 7 days.
And for anyone who's running into scheduling delays because the volume is insane, something like 17,000 providers certified in 1 year alone, there is a way to follow up.
There is. You can email fmctechhhp@tide.gov, or for a more direct approach, call the FMCSA.
And there's a trick to the phone number, right?
A great little life hack. Call the number, then press option 2, and then 6. It lets you bypass all the long automated menus and get right to a person.
That whole high-stakes environment really underscores the need for that mental adjustment we talked about. So let's get into that critical mindset shift.
This is probably the single most important takeaway. The medical examiner has to determine driver fitness for duty, period.
First and foremost, You're not their treating clinician anymore.
Exactly. You have to shift away from thinking about a treatment plan and adopt the ME's perspective, which is 100% about public safety.
So a test question might ask for the next best step for the medical examiner, and the answer might not be a therapy. It could be.
Disqualify and refer back to PCP. You're a gatekeeper. That's your role.
And the sources say you have to treat the exam like a sprint,
1 minute per question. You have to move quickly.
which means using the tools they give you on the computer, eliminating wrong answers, flagging questions you're unsure about so you can come back later.
You just can't afford to get bogged down on one tricky question. And anecdotally, we hear all the time that candidates find this test really tough.
Yeah, the pass scores we saw in the sources were things like 79%, 85%. People are not acing this thing. They're often just squeaking by.
Right. And here's where it gets really, really interesting. The feedback from people who took it.
Oh, this part jumped out at me. The critique about how current the exam content is. Or isn't.
Multiple people said the questions were woefully out of date.
And not just in a general sense. They pointed to specific examples, like diabetes.
Yes. Some questions apparently still work from the old idea that using insulin is an automatic disqualification, or that oral meds need a special waiver.
Which is flat out wrong under current DOT law.
It is. And that creates this real ethical bind for the person taking the test. You know the current evidence-based practice, but you have to answer based on the old written rule to pass the exam.
That is a critical point for you to remember. You have to study the rules as the FMCSA writes them, even if they lag a bit behind clinical practice.
It's true. And just quickly on keeping your certification, it lasts for 10 years, but you have these mandatory check-ins.
Right, at 5 years, you have to do a refresher training.
And then the big one, which started in 2023. At the 10-year mark, you have to complete another accredited refresher training and pass the recertification test all over again.
And that window is tight. No sooner than 9 years, no later than 10. Okay, let's step into the heart of this deep dive now. The clinical standards that actually determine if a driver is fit for duty.
And we have to start with the biggest category, which is cardiovascular principles.
It's all about risk, right?
It is. The entire foundation is based on the Framingham Risk Score. They're trying to screen out drivers who have a predicted 20% risk of a coronary heart disease event over 10 years.
And that's where the idea of a CHD risk equivalent comes in.
Yes. If a driver has diabetes, mellitus, or peripheral vascular disease, they're automatically considered to be at that higher risk level.
And the general rule is that most heart conditions require some kind of waiting period before you can certify someone.
Right. And if a driver has multiple issues, you always have to use the longest waiting period that applies. And all CV diseases mean, at best, an annual recertification.
Let's get to the numbers. The exam loves numbers. What's the magic number for heart function?
Left ventricular ejection fraction, LVEF. It has to be greater than or equal to 40%.
No wiggle room there.
None. This is about ensuring they have the cardiac reserve for an emergency, not just for, sitting and driving. And if an echo is inconclusive, you have to get radionuclide imaging.
Okay, let's run through those waiting periods because they are very specific. An MI, a heart attack.
Minimum waiting period is 2 months, and the criteria are tough. The driver has to be asymptomatic, tolerating their meds, have a good exercise tolerance test.
And meet that 40% LVEF standard. Recertification is every year.
And they need a new ETT every 2 years. Now compare that to a stent, a PCI.
The waiting period is way shorter there. It's just 1 week.
A massive difference, but they still need the cardiologist's approval, and they'll need that ETT 3 to 6 months after the procedure.
And for a bypass surgery, a CABG.
That jumps up to 3 months, and the sternum has to be fully healed.
What about aortic aneurysms? Can't have one of those going on the interstate.
Absolutely not. For an abdominal aortic aneurysm, it's a disqualification if it's 5.5 centimeters or more in men or over 5.0 in women.
Or just if surgery is recommended at all.
Correct. And post-op, it's a 3-month wait. And clinically, if you feel a lateral pulsation above the umbilicus and hear a bruit, that's a huge red flag. You need to refer them for imaging immediately.
Let's talk about the exercise test itself, the ETT. What are they looking for?
The driver has to be able to exceed 6 METs.
And what does that mean in practical terms?
The DOT equates 6 METs to the energy you'd need in an emergency, like changing a giant tire or wrenching the wheel to avoid a crash. It's a functional capacity test.
And the test has to be clean. No ischemic symptoms, no specific ECG changes.
Exactly. Now, moving on to DVTs. Commercial drivers are at a higher risk just because they sit so much.
So you can't certify someone with a current DVT.
Never. The max certification is 1 year, and only if the cause is known and their treatment is stable, safe, and effective.
All right, let's tackle diabetes again, specifically insulin. Even with the outdated test questions, the current process is all about the MCSA 5870 form.
That form is everything. The driver has to get it filled out by their treating clinician, the person who actually prescribes and manages their insulin.
And what does the ME need to see from the driver? What's the proof?
They need to bring in at least the last 3 months of their electronic blood glucose monitoring records.
You need to see the data.
You need to see the data. It proves they have stable control. Now, if they don't have those 3 months of records, the ME does have some discretion.
Ah, the temporary certification.
Right. You can issue a temporary cert for up to 3 months to give them time to collect that required data.
But what are the hard stops? The immediate disqualifiers for diabetes.
Any severe hypoglycemic episodes in the last 3 months, or clear signs of major complications, progressive eye disease, severe neuropathy, or really poor control, like an HbA1c of 11% or higher.
Okay, let's round this out with a few other key disqualifiers. Vision.
The big one is peripheral vision, at least 70 degrees. You have to be able to check those massive side mirrors.
Makes sense. And hearing.
A bit more lenient. You only need 1 ear to pass the whisper test at 5 feet. But also, think functionally. Cervical spine. If they have less than 45 degrees of neck rotation, that can be a DQ.
Because they physically can't turn their head to look.
Exactly. And finally, the medication minefield. Some are judgment calls, like opioids. You need a note from the PCP saying the driver is safe.
But others are just automatic red flags.
They are. Xanax, a benzodiazepine, is an absolute DQ. Antabuse is a DQ because it means they're being treated for current substance abuse.
And the big one everyone asks about, medical marijuana.
Still a DQ. Doesn't matter if it's legal in their state or if they have a prescription. The DOT and FMCSA have not approved it. Same for Chantix, actually. It's on the non-recommended list.
Wow. This deep dive has really shown just how complex this role is. You're not just a clinician. You're a public safety administrator.
You really are. You're synthesizing your medical knowledge with these very specific and, sometimes outdated federal regulations.
It's a job where the details are everything.
They are. You have to know that the LVEF needs to be at least 40%, that the post-MI wait is 2 months, that the max cert for DVT is 1 year. These aren't just test answers. They're the details that keep the highways safe.
So, as you prepare for this, what does this all mean? We talked about that warning from other practitioners that some of the exam content, especially on things like diabetes, might not line up with the latest clinical protocols.
Right, and that raises a really important question for your future practice.
It does. How will you, as a certified medical examiner, ethically handle a situation where the FMCSA's rules seem to contradict current evidence-based medicine?
Yeah.
That's the tension you have to be ready for as you move from just being a test taker to a certified